Welcome to the next episode of IBD Essentials. I'm very happy to be here with my co-host Iris Dotan from Petah Tikva in Israel. We are long-term friends and we share a lot of interest in the area of IBD, and Iris will probably introduce herself a little bit also, but today we are going to focus a little bit on nutrition because this is one of her most favorite topics in the past years. She has knowledge about everything, and I think we will have further discussions with her also about other topics. But we are always talking about the Israeli diet and certain things. But before we really go into the topic, perhaps you can say a few words about your own unit. Why did you work on nutrition? Why is it important? And then we go more into the details.
First of all, thank you so much, Axel, for having me here to discuss with you important topics in IBD. I think this is a very important part of discussing everyday issues in IBD and also highly scientific parts that we have in our work. So, like you said nicely, I'm Iris Dotan, and I work at the division chief at the Rabin Medical Center in Petah Tikva, Israel. And my focus of interest is inflammatory bowel diseases. Of course, this is why we speak here. And I think that the fact it's a wonderful choice for you to discuss today diet and nutrition in IBD, because I think that what we have in our division, which is special, is multidisciplinary team approach to inflammatory bowel diseases. And I think if we have only one message, it's not necessarily about diet and nutrition, it's about the fact that we need to acknowledge the environment in the start and in the progress of inflammatory bowel diseases, specifically Crohn's disease, but we have data also on ulcerative colitis phenotypes. So I think diet is an important topic, multidisciplinary approach is important, and in our division we have, of course, clinical gastroenterologists, surgeons, in another, of course, division, and of course we have nutritionists and IBD nurse, we have coordinators and so on to address all aspects of IBD, which is not just that the patient have multiple bowel movements and abdominal pain.
I think you summarized nicely that the MDT approach is something which is very important, and as we are talking today about nutrition, you mentioned nutritionists, perhaps sometimes psychologists. We probably will come to it later on when we come to the implementation of nutrition strategies. And you already mentioned everybody knows something about nutrition because we have to eat every day, so it's very important. And at least in my personal experience, a lot of patients ask when they get the diagnosis of Crohn's or ulcerative colitis, is it because I was eating wrong? Can I change something with the diet? We are always talking about medications and surgery and so on, but I think from the patient point of view, they want to do something by themselves, and therefore nutrition is very important. So probably there is the question, does nutrition play a role in the etiopathogenesis of IBD? Perhaps we start with this before we go to the details of nutrition and strategy, and especially the wonderful Mediterranean diet.
So, of course, you're absolutely correct that we should start with the question, in addition to what diet can do to symptoms or what diet can do to a person in person, we need to look at populations and we need to look at the disease. And indeed, we have more and more data coming in the last few years from population studies, from cohort studies, from long-term follow-ups from all over the world. Specifically, I'm highlighting data coming from the United States and data coming from Europe and the UK, of course, looking at cohorts of patients that started as healthy and then turned to have inflammatory bowel diseases, Crohn's disease or ulcerative colitis. And more so in Crohn's disease, it was already demonstrated that patients that had, and here it depends on how it was defined, but patients that had a more healthy lifestyle, and many authors try to give scores to a healthy lifestyle, not only diet, but generally a diet that avoids red meats, that avoids ultra-processed foods, which we may touch separately shortly, which avoid over alcohol from different types, and which avoid snacks and carbonated drinks. So these patients who adhered to such a diet, on one hand, and to a more healthy lifestyle, meaning, for instance, that they did not smoke and that they were physically active. So those patients, this was associated with a lower tendency to develop Crohn's disease, especially late onset Crohn's disease. So from this, we could have already have a clue, a population and epidemiologic-based clue that diet has to do with inflammatory bowel diseases. And of course, more specific data and mechanistic data, we have more than 10 years ago showing, for instance, that certain emulsifiers, specifically that were included in the diet, were associated or caused actually more colitis in genetically susceptible mice. So that was already shown and repeatedly shown later on. So we have the population-based data and we have the mechanistic data in animals to tell us the diet is very important in the pathogenesis of inflammatory bowel diseases.
Is this also probably the reason then that we see an increase in the patients with IBD in areas where it was really rare, like Asia or India, because the diets have changed there?
So, fantastic question. And of course, when we look at the surge or tsunami of IBD that we can expect in the Southeast Asia in general, and if we look at recent publications coming from wonderful epidemiologists and groups, for instance, the recent Gil Kaplan publication telling us that there is an increased incidence of inflammatory bowel diseases in areas of the world such as Southeast Asia, such as India specifically. So in those areas of the world where billions of people are living, if we may expect that they will catch up with the incidence that we know from the 20th century in the Western world, so there we should expect a big problem with inflammatory bowel diseases. And when you look at that, you say, okay, what went wrong, right? The genetics there are completely different. What changed? The genetics didn't change. The environment changed significantly. And here is, if we had a slide, of course, we will have multiple slides of different companies that distribute ultra-processed or Western or heavy fat containing food. And then we say, okay, this is to be blamed. Having said that, in parentheses, we might say, of course, the diet is an immediate suspect in everything that happens in the environment. We might think of other options. They are not the topic of your selection for today, but of course, the environment changes also regarding pollution, regarding microparticles, regarding vaccinations, refrigeration, and so on and so forth, industrialization for whatever it means. So we have more ultra-processed foods, but we also have ultra-stressed lives. So we should keep in mind that these might be, of course, other topics for research. Those are not my topics of research, so I'm not addressing them.
No, but I think this is perfect. This gives us a lot of food for further discussions. And I think this is also something which I believe is sometimes quite complicated if you talk about nutrition, because you mentioned all the different environmental factors. And for a lot of people, it may be difficult to dissect what is what. So if you have this diet and smoke, is it worse or not? Or is diet the overall most important part? And this is probably due for traveling, for sanitization. You remember the stories when we were talking that we need some infections that we're getting in our early childhood to prime our immune system in the right way. So I believe this was probably one reason why it was so difficult to really talk about the relevance of nutrition, because there's so many factors. I would go to one additional aspect. You already started to allude on this. Is there a difference between Crohn's and ulcerative colitis or indeterminate colitis? Because I always feel these are different diseases. They just have some phenotypes that are similar and they are lumped together, or is it everything the same? IBD is IBD.
So I completely agree with you that these are different diseases, and just because of our, I guess, current ignorance, we just lump them into Crohn's disease and ulcerative colitis. It's probably easier on a daily basis to treat them like that. But these are a spectrum of diseases that need to be rephenotyped, and probably not rephenotyped, but re-stratified according to what we will know on the molecular markers of them and additional markers, including microbiome related and so on. But At the moment, when we define them as Crohn's disease and ulcerative colitis, we see that there is a difference between Crohn's disease and all the risk factors, the dietary associated risk factors that I mentioned, including non-dietary, like smoking, are more related to Crohn's disease. To ulcerative colitis, the connection is less clear with what I have discussed before. However, we know that more sulfite content is probably related to the mucosal breach that is occurring in ulcerative colitis, and therefore the diets there are more focused on that aspect. They are later on in their development compared to the diets that were prepared for Crohn's disease, but I guess there will be common features. However, this issue with the sulfites is more specific for ulcerative colitis.
Great. You touched again on another point, which I would highlight. There is the microbiome you already mentioned, and the microbiome-food interaction, because the diet may also change the microbiome, or the microbiome may make something different. So this is probably also a very important area, and I know that you're also involved in the microbiota. Can you just fill us in a little bit about this relevance?
Yeah, so of course, when you're talking about diet, and I think that it's good that you chose diet because not everybody smokes, luckily, but everyone eats. So if we all eat, and if our patients all eat, and if their first-degree relatives all eat, and we have data also on that to show that first-degree relatives that adhere to a more Mediterranean-like diet, their chance of developing Crohn's disease is lower than the ones that don't do it, okay? So once you're eating, you think, okay, what is it that the diet is doing, actually? Why is diet associated on a population-based, but also on a specific patient-based, and we might touch that later. So, of course, an immediate suspect that comes then might be the microbiome, because we know the diet affects the microbiome in multiple different ways. Not all of them are recognized at the moment. And some of them are probably microbiome independent. For instance, the emulsifier part might be microbiome independent to a specific point that is shown at least by some of our studies and suggested by others as well. But let's talk about the microbiome. So we know today that specific dietary components, specific fibers, and specific dietary constituents, you might call them, like the specific fruits, specific vegetables, encourage the existence and the prevalence of specific bacterial taxa, and those might be more beneficial, or sometimes, especially with the ultra-processed foods, less beneficial to a usually genetically susceptible host if you show it mechanistically, or for a person in danger for Crohn's disease or ulcerative colitis. So this is where the microbiome in general comes. If you ask me, please ask me, because we had shown in some of our studies, so in some of our studies where we longitudinally followed up patients with specific IBD phenotypes, for instance, patients with ulcerative colitis who underwent surgery, had a pouch, and then developed pouchitis. We can even see that if patients ate specific fruits, for instance, or specific vegetables, they had more Faecalibacterium prausnitzii, which we all would like to have in our microbiome if we're susceptible to the development of intestinal inflammation, for instance. So it's not that if you eat a melon or watermelon, which were, by the way, the fruits that were associated, then I can tell you eat more melon or watermelon, tomorrow I'll see more Faecalibacterium in your feces. But perhaps this is a start of personalizing diet and suggesting what you should eat.
Yeah, I think this is another very, very important topic, and we could make a full podcast just about this, and how stable will the microbiota be if you have just a diet for a 4-week period, for a 1-week period? Do you need to make it long term? I think this would go too far for this podcast, because otherwise we will never be able to end this. But you also now touched on, and I think we are now moving a little bit more to the practical aspects. You touched on the most important risk factors: processed food, other ingredients, emulsifiers. So can you just tell us what should be probably avoided in a diet before we really move to the dietary aspects?
Yeah, so we already know, and there are a few diets that were already developed for Crohn's disease. Not all of them were tested clinically. However, if we highlight some of the diets that underwent in Crohn's disease clinical assessment, for instance, the Crohn's disease exclusion diets, the CD Treat, the Adapt, the Dine CD, the Tasty and Healthy, and the Mediterranean diet. So if you look at them in general, so you see that there are some common features. And one of the common features is that you avoid ultra-processed foods in general. So if you want to go now to your clinic, and I'm sure you already suggest that to patients, that they should avoid what is ultra-processed food. So the patients say, okay, Axel, speak German. Tell me what's not medicine. So everything that is, the carbonated drinks, the salty and sweet snacks, even the health energy snacks, okay? Of course, food that is prepared in an ultra-processed way, and a lot of our foods might answer to this ultra-processed definition. There is a specific classification, we will not go into it, and as you said, it might deserve a specific podcast about the NOVA classification and ultra-processed food classification. But this should go away, including chewing gums, including many things that we think are little things. And of course, we should also highlight, none of them is poison. I always tell my patients, nothing happens if you go and have a hamburger and drink whatever carbonated drink in order to just not say Coke in general. But okay, but it all depends on what you do 95% of the time, right? And what you do 5% of the time. So if the ultra-processed food remains the exception, then life is life, and diet is an enjoyable and an important part of life. We should start with that, right? But to avoid ultra-processed food, to avoid over-fatty food, to avoid fat from, in general, fat from animals, and to prefer, of course, we prefer as an oil, olive oil. We can discuss it if we address specifically the Mediterranean diet. But to try and adopt these more healthy-related parts of diet and of lifestyle. So to eat at leisure, to drink a lot, water, herbal tea, homemade soup, and so on, and to enjoy what you're eating, to have variety. We discuss that diversity is important. Diversity is important on your plate as well, and to make sure that the majority of a plate, when you're looking at it, is fruits, vegetables, whole grains, legumes, and so on.
Yeah, I think you now gave a lot of very practical tips, and I think still a lot of people do not really consider this. What I always find quite interesting, people believe that the smoothies are so wonderful, so they have a processed apple or whatsoever. And we know that just eating an apple would be better than an apple smoothie, for instance. And we know, for instance, that like 30 years ago, when you would go to a bakery, there was no bread. There was no bread because it would take several hours. Now with the preparations to make bread in like half an hour, there are so many substances in it, at least in Europe, and I don't know how it's in Israel or in the Mediterranean area. We have a long list of more than 400 substances that can be edited to the food, and they are all declarated, but most of us really do not know what they are, and probably we eat kilograms of this every year, and I guess you are lucky with the Mediterranean diet. We will talk about this in a little bit later. We also love the olive oil, but you mentioned the NOVA system, so I think it may be a little bit complicated, but a lot of patients would need some guidance, and at least when you go to the supermarket or you buy your food, if you have some sort of guidance, I believe this could be helpful.
So you're touching a point that we just published a paper on that specific point, and you started with the bread. So one of our talented dietitians said exactly what you say. Bread is something that everyone is eating. Now with the gluten-free hype, so maybe they eat modified breads, but those might be highly industrialized as well. But she said, okay, let's examine breads in Israel, and where everyone is eating as if Mediterranean diet, and let's see what all of us are consuming in breads. And she actually looked and examined breads that are in one very common supermarket, and she looked at all the breads, and she looked in all the breads in a health, quote unquote, food store, and she was going over all the ingredients, and she was trying to classify them into highly processed, so she gave that a red light, into non-processed, which were actually in bread that's supposed to be just, the grains and the water, and adding a little bit of the yeast, and in the middle one. And actually she had seen that more than 80% of all the breads, doesn't matter where you buy them, once you buy the breads and don't bake them yourselves, and of course no one will bake bread today themselves, so once you buy them, there is an 80% chance and more that these would be moderately processed or ultra-processed foods by themselves. So we just started looking at the breads. We didn't look in one snack that you got to your family, which we said you shouldn't. So this is a very important point, and this again touches on the importance of guidance to patients and on the role of the dietitian in that group. Because of course you, in your important positions, you cannot spend and you don't have all the knowledge to sit with the patient and to go over every cucumber and over every apple and over every piece of bread, and to make sure that the patient gets all the calories, and all the plate needs to look not only according to the diet with Crohn's disease, but also to the patient's general health. And I repeat again, joy.
No,
so that is the
joy is also very important for me, because I always have patients who refrain from everything, and then they lose their weight, they are already underweight, and I believe this is also a risk factor. We may have another podcast about obese patients, because we also have learned that this is occurring. When we started, probably it was rare that you would have an obese IBD patient, but now we have plenty of them. But for the final, I would really like to move to the Mediterranean diet, because I personally see, you mentioned some of the tasty and healthy and so on. They are sometimes complicated, sometimes they are delivered. And I think what most of the people can do, even in Germany, is sort of Mediterranean. You are lucky because you are in the area. But what is the Mediterranean diet, just from your point of view?
So yes, this is a very important question. And I think that the Mediterranean diet, you mentioned that many patients avoid many food components. So the Mediterranean diet is the opposite. And we want actually to avoid food avoidance. We know that many of our patients avoid multiple kinds of foods, fibers, gluten, lactose-containing foods, which might be right because they don't feel good when they eat them. And of course, if someone feels not good, then the dietitian can give something to substitute it. However, the Mediterranean diet is the opposite. It doesn't go into food avoidance. It doesn't go into avoiding and eating disturbances. It says we need, again, diversity. Diversity on your plate, diversity in your life, diversity in colors. So the Mediterranean diet in general means, again, as I said, is a lifestyle, to be active, to eat at leisure, to have diversity in your foods, but that's the general. Then it means that it's a plant-based food, meaning more vegetables and fruits to be on your plate and to include it. And patients, even with Crohn's disease, can consume and eat fruits and vegetables. And here is where sometimes you need to modify how you eat them, but this is for another discussion. The oils need to be plant-based oils, and we highly recommend the, of course, olive oil. Yeah, the famous olive oil. So that. To drink a lot, okay? As I said, water is recommended, but other drinks that are not ultra-processed. To have modestly, you can have red wines with its polyphenol content. So definitely that we recommend, not to consume high amounts of other alcohols. I hope that works in Germany with the fantastic beers and wines. So this is additional. The proteins, also, to consume them modestly, but if we do, prefer them not from red meat. That should be eaten, if I need to be practical, only once a week, for instance. You can consume fish, eggs, more than this, but again, modestly. And of course, to have legumes and whole grains in the diet. These are the general parts of it. And to not eat stressfully and to enjoy it. And in our studies, we also found that if you eat fruits and vegetables, may you use multiple colors. So we recommend 5 colors a day. Try to think if you ate fruits and vegetables with different 5 colors yesterday in your diet. So we have a specific adherence score to see if you can adhere to that. So a practical advice is to see for a week and see if you adhere to that. This is very simple, nothing too complicated.
No, I think this is really a really relevant recommendation, and you mentioned the tables or the pictures with the 5 different colors. This is something which we can implement into our daily practice, and I think we could continue to talk for hours about this interesting point. I think we have to meet again to really go into further details, but now I think we have to come to an end because we are already talking quite a while, and some people need to go back to work again. So thank you so much. It was a real pleasure. It was very entertaining, and I think we will definitely meet again to talk about this topic.
Thank you so much, Axel. Real pleasure.